You'll see probably the most telling thing in that packet is the map that gives you a reflection of the fatal overdoses occurring in Middlesex County up through this past weekend. The troopers from my office have now responded to 161 fatal overdoses this year. And when you look at our 54 cities and towns, I believe there are now only 9 that have not experienced at least one fatal overdose. The other piece that's important, if you were to take that map and overlay a highway map, a state highway map, you would see that many of them correspond to places where 128 or 93 pass through, because we've got a lot of people making a sale immediately off the highway and using in, for instance, a fast food restaurant, that sort of thing. So one of the pieces that has become increasingly important given those numbers is just the treatment of overdoses and to the use of Narcan. So for about the last year and a half, we have really invested a lot of our drug forfeiture money, which is the money that we are allowed by statute to seize from the sale of drugs that the drug dealers may have when they've tried in a criminal case. We can take some of those proceeds. We've used a substantial amount of that money to buy Narcan. I provided every city and town with at least 10 starter doses. It was my hope, and it has worked out in a number of communities, that the communities have then seen how effective that has been and have then gone on to buy their own Narcan for the towns. We've continued to provide as much as we can to the other communities. Nobody should be without it because they can't get it. So we've been doing that. In this training, which is our third of this type of training that we're hosting here, the first 2 were for first responders, we're now broadening that out to schools. And I really see this as part of your everyday commitment. You know, you're there to keep the kids safe. And we know that you may well see students or staff experiencing an overdose, and we want people to be trained. The other piece that I find interesting that I've learned in doing this is a number of the schools where they've been using Narcan and it's been disappearing for doses, and my question was, who are you using this on? It was often people who, much in the way that you or I might be driving and we need help and we stop at a fire station, we discovered there were lots of people perhaps traveling with somebody who was experiencing an overdose who would go to a school. They knew where there was a school, they would go to a school in the hopes that there would be a school nurse or somebody trained that would be able to help them faster than getting to the hospital or to someplace else. So I think your response may be threefold: your own students, your staff, and then people just appearing on your doorstep that may need help. And you know, obviously Narcan is neither treatment nor an end to an addiction, but it does save lives and it gives people an opportunity to have that next day when they might be able to avail themselves of some effective treatment. So we have found it to be an essential piece in our arsenal of what we're doing. And to teach us about that today, I'm really very grateful, and I will embarrass him about this, but Dr. Dan Muse, who really is doing the good work in all of this and has been on the forefront of this. He is an emergency room physician at Brockton Hospital, has very early on seen the need for this. He is a parent, a coach, an athlete, coaching and teaching hockey and lacrosse and so many other sports, and seeing how we need to have this available. And Dr. Muse has been willing to write the standing order that permits us to get the Narcan and dispense the Narcan, and also to come and really give you some good solid training so you have a good medical piece, that you know what you're doing, you can feel comfortable in doing it. It's really, you'll see it's very simple to do it, but it is always good to have that educational underpinning. So Dr. Muse has been incredibly generous with his time, with his knowledge, and with being willing to come anytime we can put together groups of people and start spreading that out. And as I said, this is what we hope the beginning of our second wave, which is getting to the school personnel, having done a pretty good job with the first responders. So I am very pleased to have Dr. Muse here today. I know you'll find this helpful. And again, we thank him for being so willing to help in this.
Thank you very much. Now, the tickets, they will be fixed, right?
They will be all fixed, yes. You do have that big get out of jail free card, yes.
Just tickets, nothing else. So, I'm actually, quite frankly, I have trained the police in Norfolk County, Middlesex County, Plymouth County. I work very closely, especially in Plymouth County, being at Brockton Hospital, but I can't say how excited I am about the second wave, because this is a difference. Police officers go in, or first responders, they go into the person's home, street, or whatever, and they will make a difference. They will give them that next chance, but they will not be there to help them afterwards. And quite frankly, I am not there to help them afterwards. They want detox, I'll assist them with that, but in terms of the day-to-day changes, the ones who might see the changes in the kids, well, quite frankly, it's the schools, especially with our teenagers. And don't kid yourself, it's in your schools, all right? In fact, how many know somebody who has died in the last 4 years from an overdose? Okay, and how many have actually been students at your school? Okay, it is, if they were using and died a couple of years later, chances are they were already dabbling in the schools. And because of that, it is so incumbent upon us to work and prevent this from happening. Addicts, few and far between, quite frankly, get clean. And it's an extremely arduous, rocky course, and it affects the whole community. These don't happen with just the kid using the drug and dying. They impact everybody around them, neighbors, friends, families, whole teams. And the worst part of this epidemic, quite frankly, as we'll talk at the end, is my profession, the medical profession, is at the forefront unwittingly as creating this issue. And the DA, Assistant DA at Norfolk County just told me today that there were 2 recent deaths in Norfolk County, younger kids, sports injuries. Okay, there is no reason for that. But these kids are getting hooked on the drugs from sports injuries at a younger age, and they continue to use them. Now that's only one segment, but that is one that we can definitely clear up and need to clear up. It's imperative upon us. And the governor, to his credit, has grabbed the bull by the horns and has made this one of his top priorities. So, and by the way, I'm a Democrat, but I like the guy anyway. Okay, our learning objectives, know how it works, recognize an opioid overdose, respond to the opioid overdose, getting help, rescue breathing, administering it. And by the way, I believe most are trainers and nurses, new coaches. This will be very quick and easy for you to assimilate. So this is one of the things, more than 1,000 people died from overdoses of heroin and other opioids last year in Massachusetts, according to figures released. Okay, increased 3.3% in 2014 compared to 2013, 33% higher than 2012. We recognize this problem, and yet here we are facing an increase of it. Okay, and this is not just a reflection of a change in society. This is a reflection also how powerful this problem is. Narcotics are an absolute scourge, and they make a lot of other things in terms of addiction look pretty easy to get off of. So 70 fatal opioid overdoses in a month was noted the last 3 months. According to state police figures, those who died were on the average 35 years old, 170 men, 47 women. Typically, it's going to be far greater in men than women, and typically what you will find out is, unfortunately, when I ask them, this is not statistically proven, but the vast majority of the women will state, I got hooked for my boyfriend. So opioids, what are they? They're a sedative and narcotic. They affect the body by reducing the pain, and also they will also sedate you, and their impact is on your breathing. And when you do have an overdose, essentially, why are you dying? It's not from the pain relief, it's from the fact that you essentially stop breathing altogether. Your heart still beats, but it can only beat for so long if it doesn't get oxygen, and ultimately that is the cause of death. And so this is what we're looking for. It'll also give you a sense of what's out there. You have the opioids, you have the natural, the semi-synthetic, and the fully synthetic ones. And so the opiate morphine is what's considered the natural. Then you have the heroin, hydromorphone, oxycodone, hydrocodone, and then the synthetic ones, which can be a real issue, especially this one here, the fentanyl. Remember, they're made in a lab. They're not coming across borders here. They can be made right here in your backyard. And when they make a big bust in terms of the heroin on the streets, how do you think they supplement the lost heroin? They make more fentanyl. And essentially this is because the person who put this together was a pharmacologist, and he wanted the slides and he got into that stuff. And these are all the different types of pills and what the equivalent doses are. And these are what you're gonna see. So it gives you an idea of what's on the street. Virtually any of these, a lot of them are trades, but these are the big ones here: fentanyl, methadone, morphine, Percocet, oxycodone, hydrocodone. When you're thinking about the big ones, it's oxycodone is the favorite on the streets, which is Percocet. And again, exactly what's happening. So you have these are the receptors on the brains. And by the way, an opioid receptor is an endorphin receptor. We naturally treat our own pains. They're called endorphins. Except when it's only in your system, you can control it. So once you add something to it, it's going to go to the same receptor and act the same way, but your body would never let you stop breathing. Whereas if you put something into your system, it can pile on, it can be too much, and too many receptor cells are filled, and ultimately you stop breathing. It is no different than giving yourself too much insulin, not eating, and now all of a sudden your blood sugar goes down critically, and you become confused and then possibly unconscious. And this is what keeps going on. They go into the receptor sites, and the medication starts blocking them, and if too many are blocked, then you've gone beyond control of the discomfort, and now you're completely unresponsive, stop breathing, and if not rescued, you would die. And it has many of the receptors, but as I said, with the receptor sites, too many get filled, that's where the danger is, and you can't control something that you put into the body, or at least the body can. Now, what else can happen? Well, there's also several different factors that can go into a person having an overdose. One is you decide to wash it down with alcohol. One case Quincy had was a guy who had his wisdom teeth taken out. He took the appropriate amount of oxycodone. However, he also liked Jack Daniels, and he decided there was no reason he couldn't have a few shots of Jack Daniels, which he would have every night. And the combination, his wife found, blew around the lips, barely breathing. And fortunately, when the police got there, because they were there first, they actually put 2 and 2 together and realized what's going on and saved his life. Okay. What else can happen is also the big one, especially for kids who go into rehab. This seems like the most dangerous period of an addict's life. You just went into rehab, you come out, well, what happens? Your tolerance goes way down. Remember, this is a chemical, so it's no different than coffee. The first cup of coffee you ever had probably kept you up for days. Now it takes about 12 cups just to get your eyes open. It's a chemical, it's a caffeine. Because your body becomes acclimated to it, you need more. Same thing happens here, but when you remove it, it becomes more of a stimulant in terms of the caffeine. And when you're talking about narcotics, when you have removed it for a period of time, maybe just a week, 2 weeks, now you decide you basically go back to using. You're gonna realize this. They're not stupid, they don't want to die, but in the effort of trying to cut down, it's not an exact science here. And quite frankly, they don't even know what they got. Last week was heroin, this week is heroin mixed with fentanyl. And now all of a sudden they think they cut down enough, but unfortunately it wasn't, and they become unresponsive, and if someone doesn't rescue them, stop breathing, and they die. That typically is the case scenario I hear over and over again in terms of the deaths. And other things that happen, variation in strength, as I said, from content drugs, is huge. You just don't know what you're buying. So, benzodiazepines is another one that can worsen the situation. Why? Because benzodiazepines, if you could take every benzodiazepine in a pharmacy, and quite frankly, if that's all you took, your breathing might go down to about 2 or 3, but of course I'm being a little facetious here, but it won't stop breathing. But you add a little bit of alcohol, a couple of narcotics, and now the combination will knock you out. Now, what's naloxone? We know that what the problem is, and now what is naloxone? Now, this is a Narcan. Its generic name is naloxone, trade name Narcan, and this has been around forever. Why do I know it's been around forever? Because I was using it when I was a resident, and I feel like I've been practicing forever, so it has to have been. Now, naloxone itself has only one function. It will knock the narcotic off that receptor site. It's a plug-in. You know, if you unplug the system, the light that goes off. If you unplug the narcotic from the receptor site, all the side effects go away. So this will come in, will come in and take its place. Why? There's a stronger affinity for the naloxone at that site than there is for the narcotic. So it has the capability of pushing it off. And once the narcotic is just floating around, it can do no harm to the body, and ultimately gets dissolved, broken down, and excreted from the body. So it will basically take away the high. It will get you breathing again. And by the way, it also throw them into withdrawals, which is why they don't really like getting it, but they prefer that to the alternative. Typically, works about 1 to 3 minutes and can last up to 30 minutes to about 90 minutes. Now, because so many people are now using it, the amount that's being used is infinitely greater than before, and the reality comes down to this. When I'm asking police officers to go out and use something and do something that they were not trained to do, I'm not trained to apprehend criminals yet. No one has asked me to do that. Alternatively, they were not trained to be medical personnel, but they have accepted that. And in the great scheme of things, graciously. Well, if they want to give it and they're nervous and so they give another dose right away, great, fine with me. I'm not going to stand here and tell them, well, listen, maybe you should have waited more than 3 minutes, check the pulse, maybe half a dose, see if they come around gradually. No, just get it in the nose, save their life, we'll worry about the withdrawals later. Now, the beauty of this drug, it has no other function in life except to kick narcotics off receptor sites. And by the way, it works with all narcotics. It does not cause a high. It has no other effects whatsoever on the body. And it can only work if there's a narcotic available. In other words, if you give it to an narcotic overdose, they will respond to it. Not only will they respond to it, they'll start breathing again on their own. If you give it to something that is not an overdose, it has no effect. It is the equivalent of shooting saline up their nose. It has absolutely no effect whatsoever, but it has also no side effects. You can't hurt the person if you give them the naloxone and it doesn't work. All that means is it wasn't an overdose with narcotics. So, at the end of the day, it is the ideal drug for the epidemic that we have right now. There, as I said, are issues, and you will send them into withdrawals, none of which should ever be an issue simply because you saved their life, and that is better than withdrawal. Now, what happens here? Well, here we have from the previous slide, those are the narcotics, those are the receptor sites, so essentially they're all full. So, that's the naloxone, so it pushes it off one at a time, causing the narcotic now essentially just to float around. It has no place to go, and that will allow the breathing to come back. Quite frankly, it's that simple. So some of the things in terms of what's going on, they talk about really high overdose. This is really something that, for your edification, there are different signs that you'll see, such as pinpoint pupils, nodding off, arousal. When you basically overdose, you're not responding. The speech can be slurred, here you're not talking, breathing is very slow. We usually use 8 or less as cutoff. Sleepy, intoxicated, but not breathing. It's caught breathing is considered like a deep high from this. And typically 8 or more breaths is considered safe. Blue lips, fingertips, obviously that's not a good sign. So in reality, again, and we have varying levels of medical professionals here. And yes, coaches at a certain level are medical professionals because you're asked to take care of kids' injuries, whether you know it or not. But the reality comes down to this. If you think a person is going to overdose, give it. Don't sit there and try to figure out whether they're high or not. I can do that in the ER. Why? Because I have multiple nurses, they're on monitors, I can watch them. If I just want to let them come out of it gradually, that's my prerogative in a safe environment. If you're at a school or on a field, you're in the parking lot because somebody decided to use on your school property, or God forbid, but rest assured it is happening, maybe not at your school, but it's impossible statistically for this not to be a case if it's not a fellow colleague, teacher, even principal. Are there any principals here? Did I just bad mouth you guys? Sorry. I knew there was a couple. Had to get my dig in. Must have been the vice principal. So the reality is it does exist, and you're not going to sit there waiting for the ambulance to come when you think that this could be it. Why? Because you don't know which way they're going. They may have be at their peak, and their breathing is going to get better, or it may get worse. So my advice, especially since it's mostly police officers that I've been dealing with, just give it. Save their life. Don't worry about whether it was a high or deep high, or that they were impending overdose. If you think it was a narcotic overdose of any sort, give the Narcan. And you already know that even if you use it, and that's not the case, you did not hurt the person. It is absolutely impossible to have any impact on them, except in the case of using narcotics. And that's essentially the same things. So environmental pollutants, yes?
We take any questions now?
Sure, I'll tell you, feel free to do it, ask questions when you want, when they come. It usually works out better that way.
Will epinephrine do anything for these people?
No. Because again, now the good question, but what's the epinephrine going to work on? It's going to work on their heart, it's going to speed up their breathing, but no matter how much epinephrine you give them, they're going to stop breathing if there's no oxygen. This is what's considered a respiratory, when unfortunately if they die, it's a respiratory death. It would fall in the classifications of like a drowning. The heart was fine, but the breathing stopped completely, and therefore there was no oxygen to the brain. Ultimately, that stopped the body and the heart as well. Okay? So all the epi in the world isn't going to be able to speed up the process. So in these cases, there's a lot of profiling going on. And part of it is that one, recognizing the symptoms, but typically you're going to find something around them, in particular a needle. Okay, a lot. The trend is to go from pills to heroin, and there's a very simple reason: it's a lot cheaper. Okay, so what will happen? Let's, for the sake of argument, talk about the sports athlete. He goes in, and quite frankly, this is a true case, gets 90 Percocet for the injury that he had to his knee. His knee gets infected, gets another 90 Percocet. So now, because of the infection, it got better, but they wanted to give it antibiotics for a while. Gets better, not quite back to normal, so they have to go and get the hardware out. So they give him another 90 Percocet. So in the course of a period of time, he was just given 270 Percocet. Rest assured, he was addicted a long time ago, probably during the 90 Percocet, quite frankly. And because of that, the doctor now smartens up and says, we're not giving you anymore, okay, because I've given you enough. Now, that's the right thing to do, but what the doctor also did was he threw him back on the street. Kid's addicted. There's no question about it. If he's not physically addicted, he is emotionally addicted. And by the way, that's what happens first. They're not using it for the pain relief. They're using for the euphoria that it causes. And I assure you, when you take sports away from an athlete, and you tell him his whole life is now destroyed because he was everything. This team was everything. They were winning. He was one of the best players on the team. He practiced and trained for this. He's keeping his nose clean because he wants to do well and get into a good college playing that sport. And now that's all destroyed. At that point in time, what happens is you give him a narcotic. Well, he's going to use it for the pain early on. But ultimately, what will happen is he's going to use that as a substitute for the emotional support it gives. It's going to make him feel good. It's going to just let him forget about everything that he lost. And shortly thereafter, he is now emotionally taking those pills. And at some point in time, it goes from an emotional addiction or craving to a physical addiction. And 270 oxycodone, I assure you, you will be addicted. But the biggest disservice, besides giving him 270 oxycodone was, he didn't help the kid afterwards. He washed his hands of the situation, which unfortunately medical professionals constantly are doing because they don't recognize what they're actually causing, and they turn around and send him into the streets because he's going to figure out where he can buy them, but after a while those pills are just too expensive, and now he's going to be using heroin. And so what do you end up with? A lot of drug paraphernalia. It'll be lying all over the place. And that's a pretty good clue that you have an overdose from heroin. And that is when, of course, you want to use it. They like to say this one, when in doubt, blowing up the stomach. And again, why not? Can't hurt the person. So hazards, just who knows where it's going to be, but in schools, it could be the parking lot, so be careful with the traffic, various bystanders, panic amongst the students. Okay, this is not something they use to, especially out in the suburbs, where it is endemic. The reality also is that we feel very safe, so when they see something like this, it really will set a lot of people into turmoil. And who knows how they'll react. Even kids start pushing each other. Hazardous materials to be around. The big ones is needles, too many people around, and you now have a crime scene as well. So how do you do it? As I said, this is extremely easy. You can see the picture right there, that's it. So before we even go on, I'll just show you what we have here. I don't recommend this because it's about $220. But it is a nifty device. Insurance companies are paying for it for families so they can use it. This is a trainer.
Contains no needle or drug. If you are ready to use, pull off red safety guard to inject. Place black end against our 5, 4, 3, 2, 1. Injection complete.
Like EpiPens, it goes right through the clothes.
This trainer may
That's
be
it.
reused for training purposes. Replace the red safety.
Kind of a voice. Now, what you're normally going to use, and quite frankly, what is a lot cheaper, is the regular Narcan. This is what you would have when you come into the hospital or the ambulance would use it. Normally, what they would do is start an IV, and it comes in 2 parts. This is how it looks. And all you have to do is pop, pop, and now you have the piece right here. There's a rubber hose with a rubber valve in there, and it literally goes into the needle in there, and you screw it in place to make the Narcan. You pop it off. Right here is a little packet that has the atomizer. This is essentially the same as your hose that you use when you put it on spray or shower. It just sprays it out. The reason for that is if you were to shoot this straight in the nose, that's fine, it'll work, but it's going to pull because so much fluid goes in at once. When you put this on, as you'll see when we demonstrate it, it just sprays it. So this is a rubber foam, you put it right up the nose and you seal the nose with it, and then you push it in. Ideally you put half of it or 1 ml into one Mary's, you go to the other side of the nose and put the other ml. I would bet that 90% of the people do it by just shoving the whole thing up the nose, and that's fine too. There's plenty of space in back because it's running all the way back to the throat. This can run all the way down the throat, all the way into the esophagus. That mucous membrane all the way down will absorb it. So as I have told them over and over again, if for whatever reason you can't get this on, it broke, you don't have one, just put it up the nose, pinch it, and shoot it in there. It will work. Others have asked, what happens if they fall, hit their face, and they're bleeding from the nose? Put it in the back of their throat. It's going to get absorbed. And while it may not be optimal, while it may not be perfect, it's better than being dead. So it does have a function. So essentially, this just shows you the picture of her, or him. Well, it looks like a her. That would be really bad on the guy. But it's shooting it up in the nostril there. Now, a couple of things that you do want to do recognize is just you don't know where the person is. So when you do approach a person with an overdose, do approach them as if it was someone who fell to the ground unresponsive. You're checking for a pulse. You're going to make sure that they do have a pulse. Otherwise, you are doing CPR. That's not to say you don't have to give them Narcan. but you have to do CPR. And the other thing, in this case, this is not one person CPR. Breathing is actually more important in this case than the compressions. Remember, the heart is fine. If you're certain that this was an overdose and their heart stopped, that means they've been down so long that they don't have oxygen in their brain, in their body or their brain. So you got to get them oxygen. And that, quite frankly, is the whole reason we use a Narcan. By reversing it, they breathe on their own, their heart is fine, so it's going to continue to pump. Now, once they breathe, it'll pump oxygenated blood to the brain. So when it does happen, obviously, don't try to do it all yourself. You still have to call EMS. You try to see if they can be responsive, and a lot of they wouldn't be the first one in my area where, especially Brockton, where in December we had 100 overdoses coming to Brockton Hospital, 7 having died. But a lot of people just, after a night shift waiting to pick up somebody, fall asleep in their car, end up with a sterile rub and Narcan. Okay. And we'll see more of it. But you know something? It was better than not having the medication for somebody else. Rescue breathing, as I said, this is a respiratory failure. It is not a cardiac failure. And administer the naloxone. No policy, you'll start CPR, make sure the breathing remains absent or slow. You try to give them rescue breaths because it's so important to be able to breathe for them. You're not doing the one-person CPR that you do that's now becoming more and more part of the training for just cardiac arrest. You have to make sure that they get some oxygen to reverse this process. Otherwise, all you're doing is pumping unoxygenated blood. And essentially, they always say put them on their side because as they do come around, they may throw up. We don't see that often. They make it sound like that's another urban legend, that when they come out of it, they're swinging and everything else. It's more like, okay, where am I? What happened? And when they do come around, it's more, they just don't know what happened. So that sense that they're violent isn't violent at all. They're confused, disoriented, so they start moving around, and they might push you away, but they're not coming out swinging. Once you talk to them, they come around and understand what's happening, and they're usually very appreciative. So that is what we've already discussed. The parts that make up the kit. These kits there's virtually only one kit that comes with it. This is the instructions how to use it. You're popping all the pieces off. You're going to put the naloxone into it there. You screw it on because it has a rubber valve that screws right into the needle, which you can see right along here. The atomizer goes on and you push it out. Now, I'm sure you're sitting there going, that sounds pretty simple. It is that simple. Okay. However, when a person, especially if it's somebody you know is not breathing, it can become somewhat difficult. So, in terms of using it, why the nose? Well, it's out of the way. It has the mucous membranes, and therefore it's easy to get to. And the reason you also use it is that otherwise you're going to have to give it with a needle. Now, the beauty of this here is that you never see the needle, but you don't want people walking around screwing needles in, shooting it into the person, because that needle is now going to be lying around, and you don't know what type of diseases that person who's been shooting up heroin may have. Hepatitis, AIDS is still out there. Fortunately, with the needle exchange, the rates have dropped dramatically, but that doesn't mean it doesn't exist. Okay? And no good deed goes unpunished, so therefore, if something bad is to happen, you're trying to do the right thing, it will happen. Just keep that in mind, so try to prevent yourself from having it occur. Okay? So at this point in time, I think we're at the point where we can actually start talking about going how to use it. And we've discussed the life pack and so on. I suppose we can go through this part before. This is just quickly to show you what we're dealing with. Nationally, heroin is about here, over here about 40%. Okay. We are also one of the few states in the country where there are more heroin overdose than car accidents. We've done a good job with seatbelts here. And Boston ranks higher than any other metropolitan area in the country for heroin mentions and emergency departments. What does that mean? We see a lot of it. As I said, 100 overdoses in a small community hospital in Brockton. And oh, by the way, before we get the wrong impression of Brockton, which is an absolute great city, 50% were not from Brockton. They came in to purchase. Okay. Your distribution centers, Boston, Lawrence Lowell, Worcester, Springfield. These are the big distribution centers for narcotics in Brockton, by the measure. So where do they come in? They come into Brockton to purchase, and also there's a lot of substance abuse facilities. So when they're coming out of those facilities, unfortunately, there's people waiting around to offer them whatever they want. And as I said, car accidents, more car accidents than we have more overdoses than car accidents. Let's see. Now, a couple of questions just to clarify. As I said, it only works on opiates. Therefore, naloxone won't work on alcohol. Okay? It doesn't work for cocaine or speed, methamphetamines, or any of the other stimulants. And at the same time, that doesn't mean you shouldn't give it, because polypharmacologic overdoses are the norm. It's not always just a pure overdose. And therefore, if you do give it, since there's no side effect, if they have been drinking and they've been taking pills or benzos and pills or God knows what else, and you give them the Narcan, once you've neutralized one of the drugs, they'll be able to breathe on their own again. And the ambulance and hospitals using nasal naloxone, yes, it's so much easier, so much safer that we're using it as well. And also when they're coming in, a lot of them, quite frankly, the ones that we're seeing in the ER, they're drive-bys. Drop them off, you come out, and basically you want to be able to rush out. You not start an IV, it works so much quicker, and you can ventilate these patients. If they have a pulse, you don't actually theoretically need the Narcan. You can ventilate them, but it's a lot easier for them to be breathing on their own than trying to breathe for them. So long as they get oxygen, the heart will continue to pump and they will continue to breathe. You'll have to breathe for them because their respiration's down, but they will continue to function. Once you remove the oxygen, then they're not going to breathe on their own without your assistance. But therefore, if you give them the Narcan, the quicker the better, because now they're breathing on their own, making everybody's job a lot easier. We keep it in all strategic locations. We have it in the ER as you enter, we have it in a couple of the resuscitation rooms, and we have it in triage. And 1 week ago, they pulled up simultaneously pulled up in separate cars, and they weren't coming together. Okay. That I hadn't seen before. And in fact, in the main lobby, we keep an ambulance stretcher because they're easier to maneuver than the stretchers, the hospital stretchers. And before, as I tell you these war stories, before I go too far with it, remember, this is happening in every ER. It's happening up here, it's happening all over. What I'm telling you is the norm. It's not an exception to the rule. So, are you protected from using the naloxone? You are a good Samaritan when you use it. You are definitely protected. That is really a real, something that they always want to know, and you're better off, quite frankly, you're probably least protected if you don't do anything, especially if you are, certain members of medical personnel. Is there a risk period for those to reoccur after giving naloxone? Not while you're with them, because we have a good EMS system. It takes time, but yes, the naloxone could wear off. The narcotic could hang around, especially if it's a long-acting one, and it could have a rebound effect. And as we already discussed, if I give it and they're not an overdose, what's going to happen? A narcotic overdose, what's going to happen? Nothing. You'll have confirmed, one, that it is not a narcotic overdose, quite frankly, which can be very beneficial for the medical staff that's taking care of the person. But two, there is absolutely no way you can hurt this person by giving it. If it doesn't work, then you might as well just consider yourself saving up their nose. You cleaned up their sinuses for them. So what we're going to do now is break down, show you how to use it. We'll come back, discuss a few things in the packets. I'll explain what you have, and then we'll get you out of here. In terms of what you're going to use, well, it's typically you're not going to actually have masks with you. The police some of them carry these small masks. They're easy to carry. If your school wanted to get something like this, It's small. The device is essentially goes over the face and then has a valve. You just pop it out here, and it's fenestrated so that essentially you're not it's not breathing back at you. And you pop it out and just use the mask itself over the face. So it makes a seal. You put this piece on, and you come right down and breathe over it. Okay. But that's really an important thing. If they don't have a pulse, you can't circulate the medication. If you're not circulating the medication, at the end of the day, they still will die. And as I said, and I want to emphasize again, this is a respiratory overdose. So what all these tables have is just water. And I can get this little sucker in here. What you'll have to do is just fill it up with saline, and then you'll end up just shooting it in. So looking at this, it's going to, as I said, it's all packaged. These have come packaged as well. You pop off the purple, yellow caps. You can see right inside here, it looks like a little screw. Inside here is a needle. You just push it together, turn it until it feels firm, and then you take the atomizer, put it over here. You can see how it just sprays it out. Okay, so what it's doing is it's going to cause it to spread, just like the hose at home. And you seal it right up into the nose tight so that the foam is right against it, and you push it in. Theoretically, half for one nostril, half for the other.
Do you pinch the opposite nostril?
Don't have to.
Don't have to, okay.
It's not. This is, quite frankly, just one of the easiest things you could possibly do. And so long as it goes into the nose, and as I said, with the sprayer one, it's going to push it further down, but it sprays it against the mucous membrane. So instead of having just a big flow in one area, you're causing droplets to spread out across the whole mucous membrane, making it easier for it to get absorbed through the skin. It is, and by the way, it is a great source for absorbing things. So it's not like this is any worse than starting an IV. It's just safer, more practical, and a lot quicker. If we were starting IVs or injecting people with needles, I assure you, most people would not be doing this. Nor could I blame them. So first off, any questions up till this point in time? Yeah.
So I'd like to put in the nurse. We're from a high school. If we went back, we used the standing order and got a prescription. Is anyone that we train allowed to use it at our high school?
It's part of the standing order.
Okay.
I'm trained. This is a train the trainer. All right. Listen. Here's the thing.
So we could buy 10 prescriptions and have them in places and train other people to be able to use it.
Absolutely correct. The more the better. You have to think about where this could occur. Okay. And
right. Our nurses during the school day could more likely happen like at a dance or a game or
correct.
An event like
And what about you just around the building and you have NA meetings? The high schools have AA, NA meetings. Some of them, not all, but this is high schools are not just for education. They have community centers. They're used by a lot of organizations. The athletic facilities are being used. Youth sports are up there. Your dad has a substance abuse problem. You happen to be up there. They're coming on after, right after the football practice, and now Pop One is going on. Okay, I mean, there are so many scenarios that could be played out that have nothing to do with the school. But at the end of the day, the school, they're on school property, and we have to be prepared.
Housing the medication, does it need to be in a locked nurse's office? Can it be easily available?
No, it really doesn't.
School specific?
It's school specific, and $40 a pop. You decide where you want it. You want to make sure it's accessible, because in the worst case scenario, it's like an AED. Oh yeah, we have an AED. It's locked in that closet. We don't want it stolen. Big help that's going to be if the person with the key's not around. It sounds ludicrous. It happens all the time. So the same thing happens with this. You want it there. And you know something? If it's stolen because it was accessible, you just may have saved somebody's life indirectly.
Are there extra trainers or equipment that we can use to train the nurses?
Take one.
Just take.
If you want one, if there's enough to go around, just take one. I can get more, unfortunately.
And the expiration date is like a year, is that how long?
2 years. Yeah, so they're typically good for 2 years. Most medications are good for 2 years. That's the other thing. So I've been handing out, these ones I've been handing out around the school districts. On April of 2016, they expired. I told them, well, don't throw these away. They're perfectly good. Drug companies take the expired drugs and then ship them overseas. They're not doing it because they're bad drugs and they're just scamming people. They're doing it because the bioavailability of that drug is fine, but the U.S. standards are such that they're going to be expired in this country, whereas they're perfectly good for months after that. So, and better to give them, even if it is expired, even if it's 2 years expired and you found it, there's still some use to it. It's better than not doing it and say, well, I'm sorry he died, but my Narcan was expired and I couldn't use it.
We had a question from the local police who were leaving it in their squad car last February. It was freezing
Yeah,
and then thawing.
probably
So
still works.
we checked with the Mass College of Pharmacy. They froze it and thawed 10 times. Still had 100%.
Yes, it would still, I didn't see where it wasn't gonna work. It actually has, and that's because its ability to work is well below the freezing point and well above the sweating point, okay? But as Officer Glenn likes to say, there's no cop who's ever sitting in a cruiser that's too hot or too cold. Okay. Just leave it out of the trunk. Yes.
Okay, I just want to make sure I have this right. Is that if we come on somebody who's not responding, needs CPR, no pulse, do we do the Narcan?
You would go in first, you have to get the blood
Like
flowing
flowing.
and breathing.
And then give them?
Give the Narcan. Remember, you can always, you treat it like a regular CPR, but at some point in time, you want to give the Narcan. Here's the difference. If this were a cardiac event, and then giving the Narcan is not going to make any difference. But say now it is, he's a 25-year-old, goes down, you see a needle, but they're not breathing. You do the CPR. You have to breathe for them because there's no oxygen in their body. They stopped. Their pulse stopped because they stopped breathing. Okay, and now the heart wasn't getting any oxygen to the heart muscle, so the heart muscle wouldn't work either. So at that point in time, you have to do CPR, you have to give them some breaths, you have to get some oxygen circulating in the body, and now when you give the Narcan, it is going to cause them to start breathing again. Whereas if it were a different type of arrest, maybe a cardiac arrest, it may not do that. Now, does that mean that it's going to work every time? Absolutely not. As I said, 100 overdoses in December, 3 a day, 7 died. They got the Narcan. These are the ones who made it to the hospital. Okay, and so essentially, and by the way, only Brockton Hospital. But the point being is 7 still died. With all the Narcan out there, they still died. If you get to them too late, they still will die. Any other questions? All right. So again, it's pretty simple to use. We're going to discuss where you stand in terms of how to go about getting it. But some of the things in terms of review, this is a major epidemic affecting all our communities. It's in our schools, and overdoses will occur. As I said, it could be any one of these people. These schools are community facilities, open to everyone. And it's going to happen, no question about it. Naloxone is the antidote. Okay, it will give a person another chance. It will not prevent the use of narcotics. It will not be an epiphany of their life, and they're not all going to line up to go out to rehab. I can assure you that 90% of the overdoses I get, they don't want rehab. They're not ready. And like any addiction, until the person wants it, you can't really help them, unfortunately. So they have died, risen from the dead, and yet they're still going to go use. They're not ready. What we do at Brockton Hospital, which I would strongly suggest every hospital in this community and in this country to do, is provide them with naloxone. If you are an overdose, you are offered 2 doses of naloxone plus how to use the medication and a list of detox facilities, and it's given to anyone who requests it. In fact, if a mother came in and asked for it, we'd give it to them. This is about saving lives, and it's about giving them another chance. But unfortunately, this is what happens, and this was a young girl who I perusing through the internet, I came across this. Her addiction, her obituary talked about her addiction. And unfortunately, we see too much of this. Now, why am I so excited about being here? When I was with the police, well, Chief Shastany, who started all this, quite frankly, because up till then, DPH had stated only certain towns can be in the pilot project. The pilot project had been going on for 4 years. It had been proven to be very successful. They wanted to keep it a pilot project, and you had to have a certain number of deaths. And Stoughton did not have enough deaths to be part of it. And so he challenged the ruling under the Good Samaritan law, which allowed this to open up to all the police departments in the state. But what the police department does is they are there first, and it makes perfectly good sense. They're on the streets, they're closer to virtually everything than the ambulance is going to be, even in really good systems. So they get there first, they give the Narcan, they bought a few minutes, and that can make all the difference in the world, because when you're talking about the brain, it is an unforgiving organ. Of all the organs in the body, it has the shortest shelf life in terms of how long it'll go without oxygen. So you can either have partial brain damage and live, or complete brain damage and be dead even if they get your pulse back, or not even get the pulse back. So minutes do count in this case. And so they essentially opened it up. But at the end of the day, they give him the second chance. And Paul said, everyone deserves a second chance, maybe 7, and they do. But what we have seen is that it's not changing anything. We are giving them another chance, but we have to change the system completely. And that's where schools come in. Listen, the impact that you have on the kids, who knows them better? Who can make a difference? And we have to educate the kids, we have to educate the teachers, we have to work with the coaches so that they understand the risk. It's preventing it. If we do not get it off the streets, if we do not change how we perceive use of narcotics, then this problem isn't going away. And keep in mind, 80% of all narcotics in the world are prescribed in the United States. 80%. That means either we're overprescribing, or the French, even the French, are a lot tougher than we are. So what we have to do is we have to educate, the patients of the dangers of narcotics in the healthcare profession, and we essentially have to change the way we're doing things. Okay? Doctors overprescribe. There's a lot of factors that go into this, but we overprescribe. We give far too many medication. A 13-year-old with a knee injury should not get 60 oxycodone to go home with. And let's think of the oxymoronic event. You just spent 6 weeks in rehab on Tylenol and Motrin because you tore your ACL or your meniscus, and now they decided, hey, it's not working, we're going to do an operation. Now because they did an operation, a procedure that's supposed to make it better, they're going to hand out 60, 90 oxycodone to you when, quite frankly, maybe 5, 10, when the pain got really bad, and using other modalities like Motrin, Tylenol, elevation ice is going to work for the injury that you just fixed. It's supposed to get better. So why are we pumping narcotics into them? Now that's for another story for another day, because I know you guys want to get out of here. But the reality comes down to this. If we can't change the doctors, and we're going to change the way people accept the medications. And that's where the education is so important. It is incredibly important that you approach this, and that we're teaching families, friends, as coaches, athletic trainers. Listen, don't accept it. If they give you 60, rip it up. Tell them, listen, give me maybe 5, 10, and I'll take some Motrin, Tylenol, and at the end of the day, if I need more, I'll call you, but I don't think I will. And now they're not around your house, and now they're not sitting in your cabinet because you didn't use them, but somebody came up with this great idea. We're going to have a pill party, and we're going to find all the pills that you have in the house and throw them into a big pot, and then they're going to just start taking them. You can only take 1 or 2 pills before you go, I really like that high. And you're after it forever after. Yeah.
Well, back when I had to take a steroid, it was prednisone. It started me about 6 pills, 7 pills, and every day it went down by 1 dose. Why don't they do this if somebody has surgery for the opioid and start them on formula and start bringing them down step by step, so at the end his body's back to normal?
Because you really don't have to do that, you just give a few pills and just say supplement everything else. I've been working with District Attorney Morrissey in Norfolk County to see if we can change the regulation. One, because they're coming up with laws that, quite frankly, I'm not looking forward to having passed, such as any addict who comes into, who is an overdose, has to be held in an emergency department for 72 hours, 3 days. Okay, and then it's still gonna leave. But at the end of the day, I calculate that that person's bed occupied by that person will prevent us from seeing 12 other patients. Now, if I have 6 overdoses come in that day, that is 72 beds that aren't available for patients. 72 patients wouldn't be able to use that bed. For them to, and now, where am I putting them? I want to take the legislator who came up with this brilliant idea, I want to plop him down in a chair outside of his office and say, now sit there for 3 days, you can't sleep, you have to ask for your meals, and you have to ask to go to the bathroom. And let me know how you feel at the end of 3 days. Right? Then tell me if you want to do it. But what I would like, and the other ones is that they're going to say don't prescribe more medications than, like, say, 3 days. Even that, I don't want to be telling doctors how to practice medicine. But I have no problem suggesting that if you give more than 3 days of medications, narcotics, that you have to call and see how the patient is doing, which is good care, because if they're still having problems still using them, then you should know about it. Alternatively, I don't know a doctor who's actually going to give more than 3 days because they don't want to have to make a phone call. So you basically indirect do an end round, and you, one, will actually provide fewer narcotics, and two, if they do prescribe more, you will force them to check up on their patient instead of being seen in 2 or 3 weeks when the problem now manifests itself, which could have been taken care of sooner. So I don't know if it will happen. No one actually invited me up to the State House to talk. So let's go through what your package shows. Now, first and foremost, I want to make one thing perfectly clear. I can't tell you to go about and use it. That's for your superintendent, your board of selectmen, whoever. I don't think anybody's going to say no, considering that the governor considers this a mandate as well. So that's number one. Now, the next issue was after they say, you know, we want it in our schools, we should do it. Now you go back and find out if you have a school physician or a town physician or a physician who will sign for it. You might be enlightened as to how many will say no. That is why I have no problems being your medical director. So, in the packet, you'll have a standing order. That standing order has been signed already by me, and it is good for anybody who has come here and been trained. And you are also, quite frankly, a train-the-trainer now. So you can train anybody under this standing order in your schools to use it. All right, there's some other information in here that you have in terms of about overdoses, you know, handout about it. And then the other things that you will need is going to be a memorandum of agreement. If you fill it out and send it back to me, great. If you don't, well, honestly, I still would encourage you to use it. I just sort of like knowing where my name is being used, okay? You're going to need this form. They want you to have, if you purchase in naloxone, DPH wants this filled out for medicines. You would probably, if you have epinephrine in the schools, you'd have to fill this out as well. It's the same form, you'd only do it once. And then also is a copy of my state license, someplace in here, which is right here. This will allow you to purchase, and the form in terms of purchasing, the big ones are Boundtree and also more. When you buy it, you know, basically the easiest thing to do is call and just ask them what you need. Okay, and they'll walk you through it. One, there are other ways of getting it. You can just go to a pharmacy and buy it yourself. Two, you can talk to your police department about getting it. I don't know if I should be saying this, but some of the police departments have been assisting with this. They see it as an extension of their services because oftentimes they have police officers in the schools themselves. It's sort of how they look at it. So there's other ways of getting it. And it's the DA, yeah, we have somebody at the DA's office. It would be really nice if the DA just sort of purchased at least a couple of doses for everybody to get started. I don't know if that'll happen. So these are the ways about doing it. So at the end of the day, if you cannot find a physician in your community after your school department or superintendent or the board of selectmen states, yes, you should do this, you need a physician, you already have one. That's a moot point. And by the way, I really not only don't care, but I encourage you to train as many people as possible. You can't be there 24 hours. You want coaches, trainers, you want everybody to do it. The other thing, by training them on this, is you heighten their awareness about the problem. And people start seeing the world differently. Whereas if they're not really thinking about it, then they don't think that it actually exists. There was a hockey team on the South Shore. The team was hooked on heroin about 10 years ago. Started as just pill popping, and several of them on heroin. So don't think it's not happening, it is. And as I said, so long as physicians are prescribing narcotics, especially to young athletes, we will continue to have addicts. So any questions about how to purchase it? Yeah.
It's not actually how to purchase, but if I have an overdose or what I think is an overdose in my school, I'm gonna first call 911, then check for CPR, and then administer the Narcan.
Absolutely.
So that if I use my one dose that I have, I know EMS is on their way, and if this person needs another dose, they will have it, right?
Okay, yes, don't consider yourself in a vacuum. If you're in a really rural community, and there are towns like that out this way, it's different. You always have to consider your resources. And I have, always consider yourself as part of the team. 911's coming. They're there to help you. And they're gonna have more medications, and they can take over the care. But just remember that 2 or 3 minutes, depending when you actually saw that person, and it's not 2 or 3 minutes, by the way, it's a good 8 to 10 before you're actually going to see them, from the time you make the call until they arrive. And that's a good system, but that's how much it could be. Or maybe 2 or 3 minutes after, because the police arrive with it. But that second dose could be several minutes away, depending on how long they have been without oxygen to the brain. Could make, having that one dose, breathing even a little bit earlier on, could make all the difference in how they end up surviving. And by surviving is, you could be alive and have significant brain injuries from this, or you could be alive and have another chance and have a full productive life if you can get off of the drug.
Thank you.
Any other questions? All right. When you go through the process, you'll be able to, like the Narcan, you'll probably be able to figure out how to do it pretty easily. A little fumbling will go with it. But if you have any questions on the standing order, is my email. Don't be shy about emailing me. I'll be happy to answer any of your questions.